Hi everyone, I'm Allison Senefante, Director of External Affairs here at Live Action, and I am so excited to have a special guest joining me. Her name is Kendra Kolb. I can't wait for you to meet her. Given some of the recent news in the life movement out of New York and Virginia, I was connected to her through a mutual friend, and as soon as I got on the phone with her, I said, we've got to get you talking to Live Action and sharing your heart and your work and your passion with our followers. So Kendra, thanks for joining us, and feel free to introduce yourself to everyone here.
Sure. Thank you so much, Allison. I'm a big fan of Live Action, and I love that it was started by a young girl with a passion. You guys do such incredible work, and absolutely, I'd love to be a part of it in any way possible. I'm a neonatologist. I'm a mother, obviously a woman. So kind of on those three fronts, I feel very passionately about this issue in particular. I'm dually board certified in both general pediatrics and neonatal perinatal medicine. So definitely, have a perspective that I feel is valuable.
Love it. Now tell us, for those that don't know, about what a neonatologist is and what they do.
Sure. So most people, when I introduce myself as a neonatologist, have no idea what I'm talking about. And the reason for that is most babies are really born very healthy, do not need any kind of, help, come out kicking, screaming, and kind of go on their merry way. They really never need to meet us per se. A neonatologist is board certified, hopefully, if they pass their boards, which I have. They're a trained physician. They've gone through medical school. They've gone through residency. They've gone through an additional step of 3 years of fellowship training to specifically care for newborns who are either born early or born with a condition such as lethal congenital anomaly, some other problem that we anticipate the baby will need some support at the time of the birth.
Beautiful. So in a hospital setting, where should we picture you? Are you in the NICU most of the time? Where are you?
So I'm in the neonatal intensive care unit. You can also find me over on the OB side, the obstetric side. The OB doctors, as well as the maternal fetal medicine doctors who deal with the most complex and medically high risk mothers, will consult us on a daily basis to ask our opinion, to give guidance to mothers who are either expected to deliver early or to deliver a child with some difficulties, some problems. So you can find me either in the NICU or on the OB side.
Yeah, beautiful. Thank you for what you're doing. I bet you have some amazing stories, probably some really hard ones, but also some really beautiful ones of survival too. Now you called me after the New York Governor Cuomo talked about the Reproductive Health Act, and which allowed pretty much, it ended all kind of restriction on abortion in New York, while Virginia Governor Northam and Delegate Tran were talking about abortion through all 9 months for any reason. And you've actually been alongside these women who, those that are pro-abortion are saying, well, we need abortion in these cases of health of the mother or lethal, abnormality. So I want to give you're the expert here, an opportunity to speak into that. You already mentioned a couple things that are really interesting, complex cases for the mom. You mentioned lethal abnormalities. So go ahead and speak into that. How do you feel about this issue?
Sure, absolutely. So really, when it comes to the health and the life of the mother, absolutely, the mother's life is paramount. We need to support her. We need to protect her. Delivery is indicated, then absolutely, that is exactly what needs to happen. The caveat here is the baby does not need to be delivered dead. The baby can certainly be delivered alive, should be delivered alive, especially when we're talking past the point of viability, which is around 21 to 22 weeks here. Needs to be delivered alive, and absolutely, that's why neonatologists exist. We are there for these mothers, for these babies. That is exactly our job description, is to care for babies when the life of the mother was at risk and she needed to deliver her baby early. So again, absolutely, we value mothers' lives. We support these women. We know these women. We talk with these women. We have a heart for these women, and absolutely, if her health is in jeopardy or at stake, absolutely, the baby needs to be delivered. And again, we work closely with the obstetricians and the maternal fetal medicine docs to kind of come up with a decision and a plan that makes the most sense for both of those patients. Again, the OBs will tell you they have two patients. They know they have two patients. We know they have two patients. And we care for the littler of the patients. So absolutely, mother's life is in jeopardy. Get that baby out. We're on board with that plan. And again, if the baby is past the point of 22 to 24 weeks, we will be there. We will be there for that mother, for that baby. We will evaluate that baby and do our absolute best to support that baby. Again, there is questions on viability and some ethical concerns around that. In that 22 to 24 week zone, that's still a bit of a gray zone as far as the outcomes, as far as the survival goes. But again, we're talking after 25 weeks, it's not even an option that we provide to the mother to offer anything other than, full court press, which, includes a lot of procedures that we're very specialized and trained in to support these, small, fragile babies.
Yeah, and what you're doing is so important. You highlighted to me on the phone something that stuck with me. You said, we fight for these babies. So in the same hospital, a baby, say at 22, 23, 24 weeks, that's wanted is fought for by you and your team in the NICU. But in our country, that same term baby can be discarded, can be killed through the process of abortion.
Yeah, and I think that's, again, where it's just so glaringly, obviously, ethically is a real problem. Again, we do fight with all of our energy. We stay in the hospital 24 hours around the clock for that very reason. We know that babies who come out, that early are fragile. We need to be quick on the feet. We need to be thoughtful. And absolutely, we fight with every ounce of our energy for those babies. And I think that's what really gets me fired up is these are patients, these are children, these are babies. Yes, they are small, but yes, they can survive. And yes, they should be given a chance. I've talked with other maternal fetal medicine doctors who, are experts in what they do. And their heart is broken. They're upset. They feel kind of helpless in the situation. How could something like this happen? Again, especially when we're talking about a healthy baby, with a mother who has, some medical risks, just heartbreaking and, really something that, I think a lot of us want to take a stand for and really don't have a platform to do it.
Yeah. Well, thank you for sharing your voice on this. For those that are just joining us, this is Kendra Kolb. She's an amazing neonatologist, a mom, and someone concerned about what's going on in our current cultural climate, where we are talking about a quote-unquote need for medical abortion in the late third trimester. And so we want to shine a light on that today. We want to talk about the two main things that you're hearing as a need for late-term abortion. Those two things are going to be, A, that there is a health of the mother reason that you would need to go in and directly, intentionally kill that preborn child. And we've addressed that a little bit. And then secondly, and I want to talk to you about this, Kendra, the idea of a lethal congenital abnormality. If you could talk to that a little bit. What happens when there's a diagnosis of something like anencephaly? You could probably name a few others where the child may have a lesser chance at a life that we share. But how is that treated in the medical community, at least in your hospital, the ethos of around a child with a congenital abnormality?
Absolutely. So again, only about 3% of all pregnancies will have a baby with some sort of congenital anomaly. The spectrum of congenital anomalies is wide. Some we're talking a spina bifida, all the way to some we're talking, a trisomy baby, or a baby, like you said, with anencephaly, which is really one of the most severe anomalies that, we come across. So kind of on the, the other side, one side of the spectrum, you're really talking about a special needs child. You're talking about a child that's going to need some help, absolutely, is going to need some support, but it ultimately can survive, and again, have a pretty good quality of life. Some of these babies are thrown in that category of, babies with, anomalies that, should be terminated. Again, we're talking about a special needs child. And I have a heart for special needs children. Again, we care for special needs children. And absolutely, they're people, they're babies, they're humans, and they deserve to be fought for. When we go to the other end of the spectrum and we talk about babies who, are truly incompatible with life, babies who won't breathe on their own, babies who aren't able to ever eat on their own, babies who, truly have some very severe anomalies that are very concerning. Even in those cases, many times for mothers who hadn't had prenatal care, there can be a surprise. You go to the delivery, you go to assess the baby, and you come up with one of these children. In these cases, this is where pediatric palliative care comes in. So palliative care for these babies is an incredibly life-honoring option for these babies. And again, we're only talking about babies who clearly will not survive on their own and would not be medically indicated to put on artificial life support or anything like that. These babies, absolutely, we evaluate, we support them, we look for any signs of suffering and do our absolute best to alleviate any suffering. The beauty behind this, again, these are devastating cases. These are absolutely, cases that break your heart. But what this allows is us to support that baby, to evaluate that baby, allow the mother to say goodbye to the baby, allow the mother to hold the baby, gives her a piece of closure that, again, killing the baby inside the womb, a mother never has that, that chance to hold her child, to kiss her child, as her child passes, again, if that is what, is going to happen. Again, there's a large gray zone. There's babies who, weren't supposed to survive, but at the time of delivery, they're breathing. They're doing it on their own. Some of them need a little bit of help, but some of those babies absolutely leave the NICU. They go home. We see them come back as a 2-year-old running around, and it's babies have such a will to live, such a will to survive. And, for those gray zone babies, absolutely they should be fought for. For the babies who sadly are too sick to survive, have problems that are too severe, again, to even exist on life support or whatever you want to call it, we have a chance to evaluate those babies, to provide them with support, and again, give mothers the opportunity to say goodbye to their baby while their baby is still alive, which is such a powerful thing. Again, is that a traumatic, emotional situation? It absolutely is. But abortion does not solve that problem. And I think that's something that mothers need to know. They need to know, even in these devastating options, they have a choice. The choice being palliative care. I'm sure most of these mothers have never even heard that word, have no idea what that is. We're never offered that as an option. And these mothers need to know we are trained to do this. We will stand beside them and their baby, and we will absolutely do our best for that baby and for that mother.
So beautifully said. Yeah, I think that those are two words that every person discussing this issue should remember: perinatal and palliative care, right? So the way it was described to me is that in those cases, and I love how you laid out, there's a spectrum, right? There's kids that are maybe special needs, which are going to just need more support and love from society. That's the answer there. But there also are going to be some that are going to have a shorter lifespan, maybe a few moments, few days, few years, maybe longer. We don't know. But those also deserve to be fought for. But in cases where it's likely that is going to be a shorter lifespan for that child, that perinatal and palliative care allows the mother and family to treat the womb and those moments as like a hospice almost, where you come around the patient, you know that the time is going to be short, but you make the most beautiful memories so that you have those to hold on to later. And I heard stories of people, getting closure and taking pictures and just embracing those moments of life. Some, a pregnancy resource center I heard of, or maybe it was even an OB, was recording the heartbeat for the mom, just so that later they had something to remember the life that was lived there. And so I love those terms, perinatal and palliative care, for us all to remember and know about.
Yep, absolutely. And again, these are women that I respect, women that, I have such compassion for, and I have a heart for these women, and I want them to know, I want them to hear that they have this option. Again, some may have never been presented with that option. They, were just signed up for the abortion or told that, this was the best way. Again, the topic of suffering. Of course, no mother wants her child to suffer, but in all honesty, a child who receives a lethal injection in the womb, or even worse, is dismembered alive with a D&E procedure and not, induced fetal demise prior, absolutely, we cannot look at a mother and tell her that her baby is not going to suffer similarly. Again, we cannot monitor pain and suffering when the baby is inside of the womb. We can do that much more expertly once the baby has come outside of the womb. So for the women who are concerned that their child will suffer, again, I have a deep concern that babies who die in the womb suffer alone. Feel the pain of the needle entering their heart. Absolutely. Again, I deal with babies as young as 23 weeks, and absolutely when we, need to draw blood from them, they cry, they move around, they absolutely show us the same behavioral signs as you and I would show, or I should rather say a baby would show when they're in pain. So absolutely, it breaks my heart to think that these babies feel that pain. They could potentially even feel anxiety during the dying process with nobody to show them compassion or to ameliorate their pain as they go through that process.
Gosh, Dr. Kolb, you're going to make me cry. It is so amazing to hear you talk about the options for women that maybe face these really, really hard cases. Like you pointed out right at the beginning, they're rare. Thankfully, they are rare, but they do happen, and we have to be honest with women about what their true options are. And at Live Action, we've heard plenty of stories of women, like you said, just being signed up for an abortion. So their doctor came in and said, okay, you have a fetal abnormality. We can get you an abortion next week. And that was the options they were presented. And now there are women coming out saying, I would have chosen differently if I had known about perinatal and palliative care, if I had known about their true development, or also about the procedure, which you talked about a little bit there. And I think that's powerful to have a neonatologist talk about what the procedure actually does to a child.
Yes, again, it's actually horrifying when you deal with these babies on a regular basis to even try to picture a baby being dismembered alive. I mean, again, we're talking something that is out of a horror movie because I know these babies so well. I treat them on the daily basis. Even a baby as young as 25 weeks who I recently cared for, when I would come over to the isolette, which is the little heated box where the baby is, if I would say something to the nurse, this baby would open his eyes and look at me. I mean, how can we not say that he's a human being, that he's a patient? And that same baby in the womb is at risk for being dismembered alive. To me, it makes me irate and just something that cannot continue in the United States.
I agree. Thank you for shining a light on this. And you've talked to others. You're not alone in this. You've talked to others in your hospital and your unit. And are you getting the same feedback from them that this has got to stop? We've got to talk about the humanity of the child and the development of the child and what happens during these procedures.
Absolutely. Again, to be very frank, you have pro-life and pro-choice or pro-abortion people, medical professionals on both sides of the issue. But the majority of medical professionals that I have spoken with, especially in the neonatology world, again, really have some very serious ethical concerns about this practice, again, especially when we're talking about a viable baby who, is at that 21, 22-week mark. Because, again, these are our patients. These are babies. These are patients. I really kind of despise the word fetus because I feel that so much, injustice has been done in that name. Again, it's a name that people don't really identify with. They don't really understand. To them, honestly, it could just mean a clump of cells. Even as early as 18 weeks, some mothers may not really be showing. But her baby, it has 2 arms, 2 legs, has a head. It's starting to develop their brain, their lungs. They have kidneys. From a medical professional standpoint, that is a child. And the general community needs to be aware of that. Even as early as 20 weeks, some babies are starting to hear, starting to suck their thumb, do incredible things. I was looking at an article in a psychology journal about fetal psychology saying that they're starting to dream, they're starting, do interesting things, to hold their own hand, to hold their foot. I mean, things that are just so incredibly human. And again, to think that maybe, they're dreaming, they're learning, and that was an article that, was not pro-life. And at the end of the article, they did discuss, what do you think this does, for the abortion debate? And, clearly that's going to make it more difficult for anybody to argue that these aren't babies, these aren't human beings.
Yeah, beautifully said. Tell me, Dr. Kolb, about, you've talked a little bit about it, but what would you say to a woman if she's just jumping on right now and she maybe has been, her child's been diagnosed with a fetal abnormality, or she's not doing well, maybe she has preeclampsia or something, and she's been advised to abort? What would your best advice be to her?
Absolutely. I would start off by saying that some abnormalities that are seen by ultrasound, say at that 18 to 20 week mark, will go on to resolve and will not be seen on subsequent ultrasounds. We see that time and time again. We've even had chromosomal abnormality diagnoses that, are repeated and found not to be the case. So I would especially say, make sure that, she really understands, ask your doctor the hard questions. What exactly does this mean for the baby? Get second opinions. Most babies, it would be indicated to follow them on serial ultrasounds to see if, again, what was seen is even something to be worried about. So again, absolutely, babies who would go on to resolve whatever the abnormality was are being, mothers are being pushed to abort their children, which could be a perfectly healthy child. So I would start there. But I would say to that mother, this is your child. This baby is inside of you. You are this baby's mother. And, we're going to stand with you and your baby. We're going to support you and your baby at the time when the baby is delivered. Again, we will do our absolute best to alleviate any pain, any suffering, to support you, to support the baby, with all of our medical expertise, with all of our skills, with all of our compassion, to stand with you, to stand by you through this time. And for mothers who, have a medical problem on their own, absolutely, they need to follow closely with their OB. They need to be evaluated regularly. And if delivery is indicated early, and again, kind of at that limit of viability between the 21 to 24 week mark, we should be consulted. We should speak with those mothers. We should tell them what we know and come up with a plan before the baby is delivered. Wonderful.
Dr. Kolb, wrapping up, tell us, I don't know if you have a unique story or something to share, what your personal experiences related to this issue. I know we'd love to hear that kind of from the front lines.
Sure. Again, I think what strikes me the most is how early mothers are capable of bonding with these babies, again, to support that they truly are babies, their children, their patients. Even as early as 23 weeks, I've, sat at the bedside of parents who, unfortunately, the child did not survive. But the way that they grieve over these children is so clear to me that these are babies, these are people, these are a child. It could not be more clear. They're not crying over their scientific fetus. They're crying over their baby. They're weeping over their baby. It is an incredibly emotional experience to be a part of. But again, supports the fact that these are in fact children and should have the rights that a child has. I've also been involved in cases where babies have been born to mothers who actually wanted to abort the child, but for whatever reason decided not to. These women, many of them become incredibly attached to their children, even the ones who have special needs. And it is just beautiful to see, that they brought their child into the world and they love that child. Again, it may be a special needs child. It may be a child with trisomy 18. It may be a child with Down syndrome. But they love their babies and, their minds are changed when they see that sweet face, and that's just incredibly powerful to me. Some babies are born at home even as early as, we'll say, a little less than 25 weeks. We've had babies make it to the hospital on their own. And, we support them and they go on to live their lives. So really they're resilient, they're powerful, and they absolutely deserve to have rights. They deserve, again, to be born, to be evaluated, to be supported. To be shown love and to be shown compassion as any other child deserves.
I can't agree more. Thank you so much. It is so neat to hear from someone who serves, who really does this every day inside the hospitals, inside the NICU, taking care of these children who are preemies. They need all of our support and love, and yet in our country we allow for abortion of the same gestational age that you and your team fight for every single day. And so I appreciate you lending your voice and speaking up and saying it doesn't have to be this way. We can be better. We should be better for these children. There are so many parents, like you said, that bond with these children, even if they were unwanted at one point. And there's also so many ready and waiting to take care of these children, both adoptive families. And I even, think of articles I've read where teams in the NICU have taken a child home and said, I'm going to adopt you because we've bonded so much in your time, with them. So is there anything else you want to mention or before we wrap up?
I did want to touch a bit on the fact that this is really, an ethical issue disguised as a medical debate. Really medicine and ethics are intertwined. As a medical professional, we're taught, as a doctor especially, we're taught ethics in medical school, we're taught ethics in residency, different situations in fellowship as well. Medicine focuses on ethics, and it is clearly unethical to intentionally end the life of a patient inside the womb. Again, morally, really, you can't say it's much different, a fetus and a newborn. They especially, moments before their birth, they're morally identical. So the thought that somehow it's ethical, it's okay, it's moral to, end their lives intentionally inside the womb, is just not moral and ethical. And really, it's a slippery slope. This abortion logic leads to infanticide. It absolutely does. And an article that I came across that was pretty chilling was actually published in the Journal of Medical Ethics in 2012. And the title was After Birth Abortion, Why Should the Baby Live? So using the pro-abortion logic, they have two main conclusions. They say, again, as I would agree with them, the newborn and the fetus are morally equivalent. And then they go on, again, I don't think this is ethical, but in their logic, this is logical, to say, again, I'll quote, if criteria such as cost, being they social, psychological, economic, for the potential parents, are good enough reasons for having an abortion, even when the fetus is healthy, if the moral status of the newborn is the same as that of a fetus, then the same reasons which justify abortion should also justify the killing of the potential person when it is the stage of a newborn. This is outrageous. Again, this logic leads to infanticide. We as a country need to understand that. We need to be, again, awoken. This is the logic that will be pushed. We need to wake up now. We need to wake up quick, because logically, that is where it leads. Again, the baby with the congenital anomaly after the time of birth, absolutely, they're going to advocate that child's life should be intentionally ended as well. And that could not be more unethical. We as a country need to wake up. We need to understand that this logic leads to infanticide, and it needs to stop now before we come to that place.
Wow, absolutely. Thank you. And that comes right from Medical Journal. That is their words, not anyone else's.
Exactly.
Say the name of it one more time.
It was in the Journal of Medical Ethics in 2012, titled After Birth Abortion, Why Should the Baby Live? And again, this is horrifying stuff, and I think this is the way that this pro-abortion logic is going.
Mm-hmm. Well, now we see it, right? The veil is off. There is no way around the fact that the logic you just presented, that any reason inside the womb would justify any reason outside the womb for ending the life of an innocent child. Now we get to make the decisions of how we take this, and it changes our life. It changes the way we speak out. It changes how we vote. It changes how we counsel women and friends and family when they're in unplanned pregnancies, because we know what we're up against. So it changes everything, and I hope activates people. I'm so glad it's motivating so many. I'm sure you're seeing it too, Dr. Kolb, people speaking up and saying this has to stop. So we will continue to follow what you're doing. Please stay in touch with us. And so send any pictures of those beautiful NICU babies our way. We would love to share them.
Okay, that might be a HIPAA violation, so.
Okay, or don't. We'll wait till the parents do it.
There's enough moms out there who are just so proud of their preemies, and we're proud of them too.
So wonderful. We'll keep up the great fight for life, and our thoughts and prayers are with you. Thank you again for joining us tonight.
Absolutely. Thank you, Allison.